All right, so we're going to talk about the right heart. Last time we're going to go over this due to IT difficulties. But so we're going to talk about the intrathoracic pressures and how that interacts with the right heart failure, both acute and chronic, and somewhat of the ability to differentiate between the two. All right, so we're going to talk about two major groups that we see in the ICU, and those are patients in group 2 and group 3 pulmonary hypertension. Group 2 being driven by initially left-sided disease, which subsequently develops right-sided disease, and group 3, which is patients who have either acute or chronic hypoxia driving pulmonary hypertension. Now, it's really important, like we said a few moments ago, to recognize that the right and left heart work together, and they share different anatomical structures, but they also, you have to think of them as separate entities. The right heart is, we'll go over the anatomy very shortly, but it's a small, thin, floppy structure that deals with low pressure systems, where the left ventricle is this big, beefy, strong chamber that can deal with higher pressure systems, and therefore the dynamics of each ventricle is different, and we have to think about them as different. So when we think about the right heart, we talked about this a moment ago, we often think about the two chambers, the right and the left, being next to each other and acting very similar, but that's not really how the structure of the left and right ventricle relate to each other. So take your left hand, make a fist, okay? Now look down kind of the barrel of your hand. Take your right hand and wrap it around your fist, okay? Kind of this floppy structure around the actual strong, beefy fist. That's how the right heart and the left heart orient themselves together. The right heart is really just a tube, right? It's a low pressure tube that's thin walled that wraps around the left ventricle. And the only really thick and strong part of the right ventricle is the intraventricular system. And so once we recognize that, then you're going to really understand the anatomy and the physiology of the right heart a lot different than the left heart. Now we look at, this is a really, really cool image. It's kind of like a 3D rendering of how the left and the right heart interact with each other. But I want you to look at the geometry of where your anatomy is. So in figure A on the left, this is a normal integration of your right ventricle and your left ventricle. This is our tricuspid valve here, which I'm circling, okay? And this is our pulmonic valve. You see that they line up very, very adjacent to each other, but also further apart than what we see in our aortic and mitral valve in the left side. Okay, so if anatomy changes within the right ventricle, we're going to see a lot of adjustments in the ability in the right ventricle. Excuse me. We're going to see a lot of variability in the right ventricle being able to compensate and maintain stroke volume once we have geographical and anatomical changes. So the right ventricle is a thin-walled structure. It's only about 2 millimeters to 3 millimeters thick in diameter of the free wall. It is crescent shaped, and that may be a question that you see on your echo boards, is the actual shape of the right ventricle. So that's different than the cone type shape of your left ventricle. And then lastly, we need to recognize there are three major motions of the right ventricle. So basically the apex moves up towards the base here, okay? And as you can see where the pulmonic valve and the tricuspid valve are, you need that apex to move upwards in order to expel blood out of the pulmonic valve. You also have some twisting of the apex here. That's part of the major function of the right ventricle for contractility. And then lastly, there's a structure called the crista supraventricularis, which is basically something that connects your septum here to your lateral free wall. And it basically pulls in the right ventricular free wall towards the septum. So three major movements: the apex towards the base, twisting of the apex, and then movement of this structure that pulls the RV free wall into the ventricle, okay? Now, as the ventricle gets really big and dilated, look on your right side of your screen in figure B, the anatomical structure completely changes, right? As your volume overloaded and you have pulmonary hypertension, your LV doesn't change a whole bunch, but we see this big billowing out of the right ventricle. So that already thin wall now becomes big and compliant, which it already is, to allow more volume in there to develop a higher pressure in order to expel blood. And that's fine as a transient mechanism. However, when the RV starts to get bigger and bigger and bigger, look at the structure of your tricuspid valve and your pulmonic valve. They move not only further apart, right, that they were already a little bit further apart compared to your left-sided valves, but they also adjust where they are in their height. So as your apex moves up towards your base, you're no longer anatomically optimized to expel blood out of your pulmonic valve. And this is one of the reasons why in patients who have pulmonary hypertension, they really live on this very narrow window of volume status, because not only do they have tricuspid regurgitation, which we'll show you later, but they anatomically are adjusted, which is less advantageous than how the right heart was kind of has evolved over millennia. Another thing that's very important to recognize about the right ventricle is that the right ventricle has significantly decreased blood supply compared to the left ventricle, and that makes sense because the right ventricle, really, the workload of the right ventricle is about 1/6 of that of the left ventricle when it contracts at a normal kind of physiologic standing. So the RCA, if you look at the density of these vessels here, it's a lot less dense on your right side. And so when the right heart is stressed, its wall stress goes up, right? The volume of it goes up. There's increased workload that needs to be completed for it to expel blood through the pulmonic valve, but it doesn't have enough compensatory blood flow in order to maintain that. So the RV is a very high risk for ischemia in the setting of RV dilatation at an increased workload. And that's one of the reasons why acute pulmonary hypertension can be so deleterious to people. So this is kind of the spiral effect that we see when someone has acute pulmonary hypertension, so acute increased load into the right ventricle. Your afterload increases for some odd reason, whether that's pulmonary embolism, that's hypoxia driving pulmonary vasoconstriction. And so what happens, the RV dilates out and it gets bigger in order to maintain that stroke volume, right, to increase pressure and expel blood into this increased afterload system. So the pressure goes up there. And as we talked about before, your coronary blood flow is going to go down, right, because you don't have enough blood supply to maintain your coronary blood flow relative to the increased workload of the RV. Now, the other interesting thing to recognize is we learned in medical school that when do we fill our coronaries, systole or diastole? Diastole, right? When does the RCA fill? It fills in both, right? So as we get big and dilated and the pressure in the RV gets bigger than your diastolic pressure, you're going to start losing coronary blood flow during diastole, right? So therefore, not only do you have less blood supply than is needed relative to the increased workload, you actually decrease your total blood supply because the pressure within the chamber of the ventricle is so high that it doesn't allow that coronary to fill as well as it would because of the decreased pressure gradient, right? So let's talk about function of the right ventricle, and we talked about the three major ways that the right ventricle moves, right? The apex moves towards the base, the apex moves in a twisting fashion, and that crista supraventricularis pulls the RV free wall in towards the septum. So when we want to look at the longitudinal function of the right ventricle, we can use something called TAPSE, or tricuspid annular plane systolic excursion. So you're putting your M mode, which we spoke about a couple weeks ago, through the lateral tricuspid annulus right here, okay? And we're going to see how much does this area move up and away when it's in systole and diastole. So let's take a look at this view. So you can see the tricuspid annulus moving up and down. And you can see at the bottom of our screen the movement here. So classically, we'll see this up and down motion of the annulus. And that's what your TAPSE is. We're measuring from the peak to the base, okay? Now, there are a couple numbers that are really important to recognize for RV function. For TAPSE, the number that you're going to see in most are either 16 or 17 millimeters, okay? A normal person can have movement of their right ventricular tricuspid annulus 28 millimeters. And so once you start to get below 1.6 centimeters or 16 centimeters, that's when you know you start to have at least mild to moderate dysfunction of your RV. Now, think about a time when you can actually have relatively preserved RV systolic function, but your TAPSE is very low. What would one of those times be? So let's say someone had an inferior wall myocardial infarction, right? And a significant right ventricle involvement. Classically, you're going to see some decreased RV function, But if that regional wall motion abnormality is limited strictly to this base by the tricuspid annulus, you're going to see less movement, and it's not going to depict the full global assessment of your systolic function. So that's something that you may see on your boards, right? It's very important that when we're looking at M mode, right? Whether it's for TAPSE or MAPSE, or when we're looking at chamber size in the left ventricle, that when you have regional wall motion abnormalities, that can limit your view to some extent. So remember, TAPSE, systolic function, it's a surrogate for global systolic function, but has some limitations. All right. The next thing we're going to move on to is something called tissue Doppler. Now, we spoke about this 4 weeks ago, right? And tissue Doppler, basically, as we discussed earlier, is a computer programming system within the machine itself that cancels out fast-moving, loud noise movement like Doppler, like blood velocity and Doppler, and it just looks at slower velocities. And you can use it to assess the velocity of actual myocardium moving upwards and downwards. So here we're doing something very similar. We're putting our pulse wave Doppler at the tricuspid annulus, the lateral wall, and then we're turning on our TDI, that's our tissue Doppler imaging. So you see this red and yellow screen, and that's showing you that the computer is kind of siphoning out the high velocity movements and just looking at those lower velocity, higher amplitude movements. We start to see, very similar to when we looked at diastology, that there are a couple different waves. We have what looks like an E-primed wave here, which we spoke about before. We look at what looks like an A-primed wave here. But we didn't talk about this wave too much in our last session when we talked about diastology. And this is something called your S-primed wave. And this is the velocity of the movement of the tissue upwards towards the probe. Remember, when we're moving upwards towards this probe, we're going to see an upward velocity on our plane at the bottom of the screen. So this is another surrogate that we can use to look at RV systolic function. Now, the low normal velocity is about 15 centimeters per second, right? So that's what you or I with normal RV function are going to see, at least 15 centimeters per second of movement of that tricuspid annulus. In order to really diagnose RV dysfunction or pulmonary hypertension causing RV dysfunction, the number that I want you to remember is 10 to 11 centimeters per second. So when we get less than this, that's when we know that the patient is having decreased RV systolic function. So the two numbers that we want to remember are for TAPSE, we want to remember 16 millimeters, right? And for tissue Doppler, less than 10 to 11 centimeters per second. Now, the reason why I give you a little bit of ranges here is depending on the textbook that you look at, you're going to see a little bit varying numbers. So you may see 16 or 17 or 18 in TAPSE, and you may see anywhere from 9 to 11 for your tissue Doppler. So that's why I give you a little bit of range, but try to remember 10 and 16. Those are going to be your numbers that you're going to see mostly on your test. Okay. The same thing happens here. Have inferior wall myocardial infarction or something that's tethering that free wall, you're going to see decreased function when it may not actually mean that the patient has global decreased RV systolic function. Now, someone that has an inferior wall MI, very likely they're going to have decreased RV dysfunction, but it's important to look at the whole picture. All right. Now, we also see here, just look at the big screen. We see this, when we compare the size of the RV to the LV, we see that the RV is greater than 1:1 in size here. So the normal relationship that we see in size of the RV to LV is 0.6. So if you can, the RV should be about 60% of the size of the LV in normal hemodynamics. As someone develops pulmonary hypertension volume overload, that can move to greater than 1, so your RV can get bigger. We also can see here, look at the septum here. You see how that's bowing into the LV? So as the pressure in the RV gets high enough, where it's higher than left ventricular pressure, you're going to start to see this septum, which is shared by the two ventricles, get pushed over into the LV because your RV pressure is too high. So there's another sign called your MCCONNELL sign. Do you guys know what this is to help you diagnose? PE, right? So most people you'll see on echo reports, McConnell sign, high risk for PE. But McConnell sign can be present in all causes of acute pulmonary hypertension, right? And what is McConnell sign? Can anybody tell me? Well, let's look at the image here. So what's happening in this image?
For the apex.
Okay, so we see the apex here. Let's take a look at it there. What's happening to the apex? Is what? Yeah, it's pretty hyperdynamic, right? And what's happening to this base, the mid-basilar segment? Yeah, it's got decreased function, right? So McConnell sign is a hyperdynamic apex or preserved apex movement with a hypokinetic mid-basilar segment of the right ventricular free wall. It can be present in all forms of pulmonary hypertension. It doesn't just mean it has to be PE related. It's something to keep in mind when you see an acute pulmonary embolism, or when you see someone with acute McConnell sign and they have new hypotension, new hypoxia, that pulmonary embolism should be in your differential diagnosis. We're moving along pretty good. So pulmonary acceleration time. So basically what we're looking at here is we're looking at our pulmonic valve outflow tract. Right? So when we do our parasternal short axis view, and we tilt upwards, well, that's a very atypical aortic valve. So don't pay attention to that. Okay, and we fan upwards, we start to see our RV inflow-outflow view, right? This is basically, we look at our parasternal short axis view. It looks like this. As we fan upwards, look more anteriorly, so drop the tail of our probe down towards the body, we start to see our mitral valve, right? If we fan further up, we start to see our Mercedes-Benz sign, right? Which this doesn't look like. And if we rotate our probe a little bit to the right, we can start to see our pulmonic valve, which is right here. Remember, the pulmonic valve and the aortic valve, for the most part, are about 90 degrees separated. So when you're looking at a transverse view of the aortic valve, you can count on, for the most part, seeing a more longitudinal view of the pulmonic valve. So what we're doing here is we're putting our pulse wave Doppler in this section here, and we're looking at the flow of blood as it goes either out or back into the pulmonary artery, right, into your right ventricular outflow tract by regurgitation. Okay. So is this blood here moving away or towards the probe? It's moving away. It's going away. So we're watching the blood flow leave your right ventricular outflow tract. Now, if you have if the normal shape of your flow out of the pulmonic outflow tract is going to be relatively equal, right? So you're going to have a relatively symmetric flow. So it's going to look like a regular triangle. If the pressure is very high in the pulmonary artery, then very rapidly you're going to have equilibration, right? Here, very quickly, this flow stops, right? It goes in very quickly. It has a high pressure, but you have a high pressure back in the pulmonary artery, and therefore all of a sudden that flow is going to stop because those two chambers equilibrated. And that's what this rapid and high sloped area here with your Doppler is showing. And then it'll slow, that velocity will slow down. So we see rapid filling here, and then it slows down. So our pulmonary acceleration time is the time that it takes to get from start to our maximum velocity here. Basically, a time to equilibrate with the pulmonary artery. So our normal time is going to be greater. It's usually greater than 120, but the number that you're going to really want to recognize is 105, okay? So if your pulmonary acceleration time is less than 105, that's concerning for pulmonary hypertension. Not acute, not chronic, doesn't really matter, right? But a shorter pulmonary acceleration time is going to be consistent with high pressures in the pulmonary artery. Does that make sense? Okay. So you can use this for a couple reasons. We're going to talk about pulmonary embolism later. looking at using our pulmonary acceleration time. But there's another finding in this that I think are important for you guys to see. All right. Do you see this notching here? Do you remember in our M mode lecture, we talked about the flying W sign when we looked at our pulmonic valve? So this is early closure of your pulmonic valve because the two chambers are equilibrate, right? And now that there's nothing pushing open that valve. But then something else is opening it up later. There's late systolic notching. So when we talk about the diagnosis of pulmonary hypertension, we either think of a pulmonary acceleration time less than 105, okay, or this late systolic notching. And I'll tell you that this image right here is something that they love to put on boards, right? We don't often get this view because in our patients with acute hypoxia on the ventilator with hypotension, getting an RV outflow view is very difficult in these patients. But so it's a little bit less useful in clinical practice, but I can tell you, you are going to see this image on your boards and the diagnosis will be pulmonary hypertension, okay? So PA acceleration time less than 105 or late systolic notching. These are two of your signs on Doppler imaging of your pulmonic valve. So here's another view. We have very early equilibration. Your pulmonary acceleration time is very short here, right? But then also in some images, you start to see this late systolic notching. And that's probably due to respiratory variation, right? As you breathe in and out either spontaneously or with mechanical ventilation, you're going to have changes in intrathoracic blood flow, right, due to changing of intrathoracic pressures. So you may see in different circumstances, whether you're on mechanical ventilation or spontaneously breathing, that intermittently with patients with pulmonary hypertension who don't have notching in these images, as your respiratory dynamics change, you may show signs of that, okay? And that's the reason for variation there. All right. So here's another image of the same thing that we're looking at. And up top of the screen here, we can see that view that we're talking about. So we see our aortic valve, our tricuspid valve. This is our right ventricular outflow tract here. And this is our pulmonic valve. Okay, and that's the image that we're looking at. Again, PAT less than 105 or notching, right? Those are two big signs that you'll see. All right. So let's move on to a couple hemodynamic parameters that you guys can use in your practice. In 2 weeks, we're going to evaluate hemodynamics in general. So we're going to go over Doppler in a deep dive. So I want you this week just kind of accept that these Doppler assessments are reality and just recognize the equations that you're going to use over and over again. And then we'll dissect this equation next week so you understand each what goes into each part of the equation. We use Doppler to assess the changes in pressures across chambers, right? So as blood goes through a chamber that's large and then through a smaller orifice, right, you have to have preservation of energy, right? So your kinetic energy and your potential energy has to be equivalent whether blood's going through here or through here, okay? So velocity is going to increase in this narrow region, right? And the pressure is going to decrease. Here, your velocity is going to be slower, okay? Think about a hose. You have a hose that's on with water, and then you want to clean your car. So what do? You partially occlude the opening, right? And that allows that water to go out at a faster velocity. And that's how, using Doppler assessment, that we're using the same principle of preserved energy through the changes in size of the orifice. So the equation that I want you guys to know is 4V squared, okay? And that's going to help you determine the differences in pressures across chambers, all right? When we look at our tricuspid regurgitation, we're using this to diagnose our PA systolic pressure. And our PA systolic pressure is going to be 4V squared plus our right atrial pressure. And the velocity we're using is our peak tricuspid regurgitation jet velocity. We're looking at our pulmonic valve. We're using this to determine our PA diastolic pressure. Okay, so when we look at the end of diastole, we're looking at this segment here. And so in order to find our PA diastolic pressure, we're using the equation 4V squared plus our right atrial pressure, and we're using our end pulmonary regurgitation velocity. All right. So we're going to go over these in great detail in 2 weeks, but these are important in the assessment of not only RV function, but RV pressure and determination if something's acute or chronic. All right. We'll come back to this a couple times through this lecture. So this is what we spoke about before. This is Bernoulli's equation, right? This is the change in pressure is equal to 1/2 blah, 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 all this stuff. What's nice about Bernoulli's equation is a couple things we can cancel out that we don't actually really need to account for when it comes to echocardiography. The first is we don't care about the viscous friction, and we don't care about the flow acceleration within this. So here, all we're looking at is convection acceleration. That's the change in velocity as you go across a smaller orifice here, okay? Why does this become 4 all of a sudden? And basically it's because this symbol here that looks like a P is the mass density of blood. And so as you try to convert that over to our to the math calculations that we're going to use for this, for centimeters per second or meters per second, this turns into 4, okay? So again, we'll go over that in two weeks, but the change in pressure is going to equal 4V squared. And that's because it's the velocity is so low proximally to the change that we don't even account for it. So if the velocity is less than 1, right, 0.1 times 0.1 is basically a number that doesn't matter. So when we add that into the calculation, you don't even have to account for it because the velocity pre-orifice is so small. Now, when you're talking about other movements against other changes in orifice shape, like a patent ductus arteriosus or a PFO or something like that, you're going to use that same velocity. But when it comes to assessment of your tricuspid regurgitant jet and your PA diastolic by your pulmonary regurgitation jet, you only have to account for the velocity that you measure. Okay. So again, we'll go over this in a couple weeks, but knowing these are going to be important for the questions we're going to go over later. So again, our PA systolic pressure is calculated as 4V squared plus our right atrial pressure using our maximum tricuspid regurgitation jet. Our PA diastolic pressure is going to equal 4V squared plus our right atrial pressure using our end pulmonary regurgitation jet. Okay, and that's under the same view that we showed before, where we have our aortic valve here and our right ventricular outflow tract above it. All right, same view that we had for our pulmonary acceleration time. Now here's we put all this together and we look at someone who has RV pressure or volume overload. Okay. So here, what do we see? We see a parasternal long axis view, and we see a very big right ventricle, and we see the septum is a little bit bowed inwards toward the left ventricle. Okay. We look at our other images here, and we see a big dilated right ventricle compared to the left ventricle. See the volume in the right ventricle, how much bigger it is compared to your left ventricle? Looking close at this image, we also see significant regurgitation. So when this contracts, we see blood flow moving retrograde, right? And why is that? Because the pressure is so high coming out of the right ventricle that blood flow is going to move backwards into the tricuspid valve, because the blood flow is going to go through the path of least resistance, the lowest pressure area. But also because the right ventricle is so big, what happens? It pulls the annulus outward. So now there's actually not full coaptation of your tricuspid valve because the chamber has dilated so much that allows for decreased pressure still through the tricuspid valve, and you're going to have tricuspid regurgitation. We also see a big dilated IVC, and there's minimal respiratory variation through that, right? And that shows us that we have high right atrial pressures, okay? We look at our TAPSE visualization here, and we see that the number is pretty small, right? And then lastly, when we look at our tricuspid regurgitation jet here, we find that our TR max is 322 centimeters per second, right? And we want this to be meters per second. So it becomes 3.2. So 4 times 3.2 squared plus our right atrial pressure is going to give us our PA systolic pressure. So depending on what our right atrial pressure is, we're going to add that to this calculation that we have here. So 41 plus right atrial pressure. Now, if our right atrial pressure is 15, right, then we have pretty severe pulmonary hypertension, right? So our PA systolic pressure is going to calculate at 56. So let's just go through a couple of our images again. We have a big dilated right ventricle here. We see the right ventricle is dilated with significant tricuspid regurgitation here. We see a plethoric, non-variable IVC because you're having a lot of blood flow moving back into the IVC. And because the pressure is so high, blood flow is not moving into the right side of the heart as well, further dilating that IVC. We see a TAPC, which is somewhat limited. And we see a higher tricuspid regurgitation jet consistent with higher right-sided pressures. Now, what's the difference between someone who has acute pulmonary hypertension and chronic pulmonary hypertension? If they've had chronic high pressures in their right ventricle, which we talked about that it's a small, thin, flimsy structure, what's going to happen to that structure? It's going to eventually compensate. It's going to get big and strong. If I go to the gym every day for 5 years and I lift a ton of weights, what's going to happen? I'm going to hypertrophy my muscles, right? And so the same thing happens with the right side of the heart. So let's look at a couple of the pictures here. We see a big dilated right ventricle in both of these images, right? When we compare the size of the ventricles, we see that our right ventricle is probably a little bit bigger than our left ventricle here in relationship. We also see all these trabeculations? These are unique to the right ventricle. And so you have increased volume and density and size of the trabeculations within the RV. And that's going to hint that this person potentially has chronic pulmonary hypertension rather than acute pulmonary hypertension. And then most importantly, I want you to look at the septum. So what's happening to this septum here? What are you seeing there? What shape is that left ventricle? If you had to give it a letter. It looks like a D, right? Your septum is flattened. Now, we remember that your left ventricle and your right ventricle share the intraventricular septum. And because the left ventricle is so big, normally under high pressures chronically, it's going to therefore have a bigger, stronger ability to develop a higher pressure. So the septum in a normal physiologic state is going to do whatever the left ventricle wants to do. However, if your right ventricle is hypertrophied, right? And now it's basically going to take over that septum. It's going to push the septum over into your left ventricle because the pressure here is higher, and therefore going to push the septum over. Now, in the setting of pulmonary hypertension, we care about when this is flattening or straightening. So in systole or diastole. If you have isolated diastolic intraventricular flattening, you have increased RV volume overload. Okay? If you have flattening of the septum in systole, and usually diastole associated with that, you have RV pressure overload. Okay? And that's a very, very important thing to understand. If someone has chronic pulmonary hypertension and their mean PA pressure on a regular basis is 55, are you going to always have a flattening of the septum if a patient has a baseline mean arterial pressure of 50? Probably, right? So flattening of the septum can be chronic in some patients because they live at such high mean PA pressures and RV pressures, right? And so this is why understanding chronic versus acute pulmonary hypertension is very important to recognize. Because if you over-diurese that person who has chronic pulmonary hypertension with some flattening of the septum and systole, but the shape comes back to normal in diastole, then we recognize that person has RV pressure overload, but not necessarily RV volume overload. So it's very easy to look at an echo and say, you know what, this person's pulmonary hypertension, diuresis, 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 when you could be making the incorrect diagnosis based on echo findings alone if you don't understand the physiology behind everything. So diastolic flattening and isolation of the RV is volume overload. Systolic flattening of the septum is consistent with RV pressure overload. And that is something that I guarantee you're going to see on your boards. All right. So here we see a couple other findings that are really important. So if someone who has, we don't even see the number here, your pressure gradient's around 60-ish. So 4V squared plus right atrial pressure. Our velocity appears to be about 4.1 meters per second, right? 4.1 squared times 4 plus our right atrial pressure, right? Let's say our right atrial pressure is 15. What's going to be our PA systolic pressure? Yeah, it's going to be high, right? It's going to be at least greater than 60, right? A big dilated right ventricle here, okay? That's pushing over our septum into our left ventricle. But it's hard to visualize, but there's a reading up here of 0.72 centimeters. 0.72 centimeters. Do you remember the size of the right ventricle we talked about early in this lecture? So 2 to 3 millimeters. So if somebody has a RV free wall, which is 7.2 millimeters, that's pretty hypertrophied, right? So if your RV free wall is greater than 5 millimeters, that is highly suggestive of a chronic process. Right? The other thing that's very interesting here is if you have a flimsy, thin-walled RV, do you think you can develop high pressures? No, there's a limitation, right? If I'm, very small and I have low muscle mass and I go to lift a heavy weight, just because I want to lift that heavy weight doesn't mean that I can lift that by developing enough pressure in my muscles, right? I don't have enough contractility force. So if you have acute pulmonary hypertension, you classically will not be able to develop a PA systolic pressure over 60 millimeters of mercury, right? So these are two numbers that can help you with chronic versus acute. So if your PA systolic's over 60, you very likely have a chronic component. Doesn't mean you can't have an acute component with it, but you probably have some chronicity. And if you have your free wall that's greater than 5 millimeters, that free wall has hypertrophied, then that's consistent with some chronicity to it. All right. And last, this may be our last slide before we get into our questions, is the 60-60 rule. And you'll see this when it comes to pulmonary embolism. This brings just a lot of the things that we spoke about. Here we have our PA, our pulmonary acceleration time. And what do we see? We see a very steep slope here, meaning the equilibration between the pressures in your right ventricle and your pulmonary artery equilibrates very quickly because you have high PA pressures. So we see that this is less than 60 milliseconds. Okay, and remember, abnormal is less than 105. So this is severe increased pressure in your pulmonary artery. So we also see that our tricuspid regurgitant calculations gives us a PA systolic pressure less than 60. So if you have a PA systolic pressure less than 60 but greater than 30, right? You need to have elevated pressures, but it's not high enough to meet chronic component, and you have a very quick PA acceleration time showing chronic pulmonary hypertension, that this is highly specific for pulmonary embolism. Okay? So 60-60 rule is your PA systolic pressure less than 60 and your pulmonary acceleration time less than 60. Okay? All right. So let's move into some questions. Does anybody want to read this one out loud? You got to read it loud so they can hear on the other end.
Which of the following is true about hepatic vein Doppler pattern in patients with severe tricuspid regurgitation? A, in severe tricuspid regurgitation during sinus rhythm, hepatic vein Doppler always shows a prominent systolic flow reversal wave. B, in severe tricuspid regurgitation during sinus rhythm, systolic flow reversal wave peaks in late systole. C, in the absence of severe tricuspid regurgitation, systolic flow reversal may occur in the setting of right ventricular dysfunction. D, none of the above, and E, B, and C.
So is A an answer? So severe tricuspid regurgitation during sinus rhythm, hepatic vein Doppler always shows a prominent systolic reversal wave. No. Okay. In severe tricuspid regurgitation, systolic flow reversal peaks in late systole. Anika shaking her head yes? Okay. In the absence of severe TR, systolic flow reversal may occur in the setting of right ventricular dysfunction. Okay. So none of the above can't be answered. So does that mean B and C is correct? All right. So what's nice is I didn't talk about anything with the hepatic vein, right? But you all kind of knew already what we were talking about, which is great. So if we look at our IVC, it's going up into our heart, right, which is here. We have a vein that comes off called our hepatic vein here, all right? Now, why do we measure the Doppler of our hepatic vein versus the Doppler of our IVC? Notice that? We never measure IVC Doppler, right? That's a good thought. What angle do we care about for Doppler, right? We need the velocity to be changing as it's going towards or away the probe. If the blood flow is going up and down the IVC, there's going to be no change in frequency as the flow goes by because you're measuring this way, okay? So basically, we put our pulse wave Doppler in the hepatic vein, and we see a couple different flow patterns. So we see an A wave, which is our atrial kick, right? So the atrium contracts during diastole and pushes blood flow back up into the hepatic vein, right? So the atrial contracts, it pushes a little bit backwards too, right? Not just into the ventricle. During systole, we talked about this a little bit with our pulmonic valve assessment, right? Your annulus, your tricuspid annulus is going to move upwards. So as this contracts, this is going to move upwards, making a more negative pressure in your atrium, and you're going to have blood flow that's moving up into the atrium to fill the atrium. And then in diastole, when this is at a low pressure system filling, you're going to have filling upwards, and that's why the blood flow is going to be going this way, right, away from the probe, right? So a negative deflection on the probe. So A wave is our atrium contracting, pushing a little bit of blood back into the IVC and up into the hepatic vein. In systole, your S wave here, as the annulus moves upwards, it's going to put a little bit more negative pressure in your atrium, and again, you're going to fill. So blood's going to come out of your hepatic vein into your IVC. And then diastole, when you classically fill everything and you have a lower pressure, again, you're going to fill out of your hepatic vein into your right atrium. Does that make sense? So this is a normal wave pattern. Right? So here, we start to see some increase in filling pressures on your right side. And we see that your tricuspid, because you're so full of high pressure, as you contract, right, as you contract this and move upwards here, there's still high pressure within this system, so you're going to have less positive flow filling up into your right atrium, right? You maintain your diastolic filling early in this increased pressure of your RV. As your RV pressure gets higher and higher and you have restricted filling into your right ventricle because it's big and beefy and having a high pressure of high volume in that chamber, we're going to see that you start to develop some systolic reversal, right? Because as this contracts, your right ventricle contracts here, the pressure is so high up in your pulmonary system, your pulmonary artery, that some of the blood flow is going to need to go backwards, right? It's going to move retrograde. Not all of it can go forward, so blood flow is going to go the path of least resistance backwards into your right atrium, and then subsequently back into your hepatic vein. And so that's why we see a little bit of a reversal in systole here. and you maintain your diastolic flow pattern because you have to fill during diastole. There is blood flow naturally. Really volume overloaded, really high increased PA pressures and RV systolic pressures, we start to see our A wave and our S wave, they merge, okay? And so we see one wave here. So this is something called biphasic motion of your hepatic vein, right? So basically, we have a normal pattern, right? Where you have an A, an S, and a D. As you start to get increased pressure in your right-sided system, you lose that filling, right, into your right atrium, and you have still a triphasic, but predominantly your systolic wave is going to move in reverse. And as you have very high pressures, you have this to and fro motion of a biphasic hepatic vein flow. All right. Pulmonic pulmonary veins and hepatic veins can be very complex when you're thinking about it in your head. Just simplify it and think of what's happening during each of those waves. So what's happening during your atrial kick, what's happening during systole of the annulus moving upwards towards the apex, allowing blood flow to fill in. And as the pressure gets higher and higher and higher, the blood flow can't move out of into the pulmonary system because the high pressures in the pulmonary system. It has to move retrograde back into your hepatic vein and IVC. Right.
Hey, Mike,
Which patient has the highest right atrial pressure? This one's a pretty straightforward question. So IVC diameter of 1.8 centimeters with significant respiratory variation up to 0.8 centimeters. Max diameter of 2.1 centimeters with respiratory variation down to 0.9 centimeters. 1.9 max and respiratory variation a little bit less, down to 1.3 centimeters in diameter. 2.3 centimeters that goes down to 1 centimeter with respirations, and 1.5 centimeters maximum that goes down to 0.7. So this is the chart. You will be tested on this, okay? And we're going to talk very honestly about right atrial pressure assessment. So if you have an IVC that's less than 2.1 centimeters with greater than 50% collapse, that's estimated at 3 millimeters of mercury. If it is less than 2.1 but has less than 50% collapse, that is estimated at 8. The same goes for if it's greater than 2.1, so big dilated IVC, but there's greater than 50% collapse, so a lot of respiratory variation. That's also going to be estimated at 8 millimeters of mercury. And lastly, a big dilated IVC that does not have respiratory variation, that right atrial pressure is going to be less at 15 millimeters of mercury. So this is what's used to estimate right atrial pressure in echo and calculations. In clinical practice, when you truly are trying to measure your right atrial pressure and compare it to IVC assessment, there's a lot more variability. It's a lot less reliable as a true calculation of right atrial pressure. In fact, some more recent literature tells us that SVC variation and SVC changes are more consistent with right atrial pressure because you're less prone to intra-abdominal fluctuations in pressure. So someone who's had a recent surgery, has intra-abdominal hypertension, is coughing a whole bunch, right? Those patients are patients who are going to have a less reliable right atrial pressure assessment. But this is what's tested, and this is what's used in classic echo for right atrial pressure estimation.
Hey, Mike, can I ask a question?
Which of the following tissue Doppler velocities is expected in a 36-year-old patient with primary pulmonary hypertension of 4-year duration? So relatively chronic pulmonary hypertension in a 36-year-old patient. So septal mitral annulus systolic velocity of 16, lateral mitral annulus early diastolic velocity of 14, septal mitral annulus early diastolic velocity of 13, tricuspid annulus systolic velocity of 15, or tricuspid annulus early diastolic velocity of 13. This is a hard question, but think back to our diastology lectures a little bit, right? That's going to help you. So our septal mitral annulus velocity is, your septum is where? Here? So if this moved up about 16, is that good or bad? Good. Okay. All right. A lateral mitral annulus. Lateral mitral annulus early diastolic velocity of 14. Good. Septal mitral annulus early diastolic velocity of 13. Okay. Tricuspid systolic velocity 15. That's pretty good, right? And tricuspid annulus early diastolic velocity of 13. It's okay. So they're all pretty good, right? Nothing crazy. If someone has primary pulmonary hypertension, which of these two mitral valve annulus will be affected? What's that? So your mitral, so this will be affected because it's shared with the RV. You would expect, if they just have primary pulmonary hypertension, you would expect this to be affected, right? This will be affected, this would not be affected, right? So your lateral will be normal. So you would expect normal lateral, right? If your septum, if you have RV dysfunction, your septum's going to be down, so this isn't right, right? Again, this is going to be down, that's not right. Your tricuspid velocity, why would this be good in pulmonary hypertension, right? And why would this be good in pulmonary hypertension? So the only thing that makes sense clinically in isolated right-sided disease would be that your lateral wall of your lateral mitral annulus of your left ventricle would be preserved. Everything else is limited. Okay. Dr. Bartok asked a question. Any mention of hepatic venous systolic filling fraction for right atrial pressure assessment? Is that not widely accepted? So it actually is. We're going to go over. I think there's a question on it later, so I'll go over it in a little bit. In which of the following cases, and he probably has access to my slides. In which of the following cases may hepatic venous flow predict right atrial pressure? So 50-year-old man with mid-diastolic rumble, a whole systolic murmur of the left sternal border, a woman with postoperative dyspnea and paradoxical pulse, 65-year-old with a heart rate of 40 beats per minute after bypass surgery and counted A waves in his jugular venous pulse, a 53-year-old man with low voltage EKG, postural hypertension, LV posterior wall thickness of 18 millimeters, or a 45-year-old man received a heart transplant 6 months ago. So what is this question really asking us? It's saying we can use hepatic flow for assessment of right atrial pressure or estimation, right? So if they have biphasic flow patterns that we talked about before, then that's consistent with high right atrial pressures, right? Because everything's going backwards into the hepatic vein. So exactly what Dr. Bartok's asking about. But this question is asking us, in what clinical scenarios is hepatic vein flow not reliable for us to use as an estimation for right atrial pressure? And this is important, right? We don't want to make incorrect diagnoses based on data that we're not sure of, right?
So which of the following case we can use hepatic flow to predict RV?
So let's go through and cancel out the ones that are not reliable. So when would our flow be affected? So if there's a problem with our tricuspid valve, that would make sense, right? So if you have tricuspid regurgitation or tricuspid stenosis, right, that's not helpful. If you have a history of a heart transplant, not helpful. If you had recent cardiopulmonary bypass, right, remember that they kind of get into the pericardial space and you can have pericardial inflammation, and that's going to really affect filling, right, because you have inflammatory changes that's limiting filling, right? So post-op, less reliable. In fact, if you go look at all of our post-cardiac surgery patients, you are going to see intraventricular changes. You're going to see septal changes. You're going to see things that don't make sense based on your other patients. So again, with these patients, you have to be very careful in your diagnoses of volume status by echo alone. Understanding the physiology in general is really important. We'll talk about those at a later date. So post-op, AV block is going to also cause some trouble. And then we talked about pericarditis. And that's very similar to here, right? It's not just pericardial changes, but inflammatory changes in the pericardium. So mid-diastolic rumble, whole systolic murmur at the left lower sternal border. Good. So this is out, right? Tricuspid's involved. Post-operative dyspnea and paradoxical pulse. What is this related to? This is pericardial compression syndrome, right? This is related to pericardial inflammation post-operatively. So not reliable. 40 beats per minute after bypass surgery and Canon A waves in the jugular pulse. No? Good. Low voltage EKG, postural hypotension, LV posterior wall thickness of 18 millimeters. Looks like somebody has hypertrophic cardiomyopathy or a cardiomyopathy, right? And someone who received a heart transplant 6 months ago. Okay, good. So our answer is D. Does that make sense? So basically what we went through here is, yes, you can use your hepatic vein flow, just like Dr. Bartok was asking. These are the limitations for when you can have false positives, right, for biphasic flow. So you have to be very careful with these specific patient populations.
But why low voltage EKG? In what way?
Like, could this guy have pericarditis?
Or peripheral infusion.
Yeah, but that doesn't. But we don't see any changes here with that, right? So I have a posterior alveolar wall thickness, but that's not telling me that the pericardium's inflamed, right? It's showing that someone has probably some obesity and LV hypertrophy. What is the pulmonary artery systolic pressure of a patient with a peak TR velocity of 3 meters per second and a JVP of 15 centimeters? So this is a tough question because we didn't talk about jugular venous pressure and then how that relates to right atrial pressure. So what I'm going to do is I'm going to make all of your lives easier, and I'm going to tell you that your JVP, right, it times 0.7 equals your right atrial pressure. That's what I'm going to make your lives, because you're not going to see that on your boards. All right? Why don't we calculate it together? Okay. Plus 10. Your right atrial pressure is 10. Good. Equals what? 46. Good. Everyone used their brains except Yanika, who had to use her phone. I just want everyone who's logged in remotely to recognize that. This was our weekly bereavement of Yanika. All right. So I use this as a good reminder of our calculations, right? So this is our tricuspid regurgitation jet, so max velocity, 4V squared plus our right atrial pressure, right? For our PA diastolic pressure, it's 4V squared plus right atrial pressure using the end diastolic pulmonary regurgitation velocity, right? And that's how you calculate those main numbers. Any questions with all of those? I'm going to blow your mind with one more thing that's not on this for some reason. So if we look at a pulmonary acceleration time, so we have, basically we're looking at this area here. It's not really set up for that. Pulmonary acceleration time here, right, that we spoke about before. And our time here to our peak, that's our PAT. You can actually use that to calculate your mean PA pressure, right? This, I don't remember being on the boards, but we like to go a step beyond what's learned on the boards here. So the calculation number that you're going to need for this is your mean PA pressure. And there's a couple different calculations, but they all end up being similar after you adjust the numbers. Okay? It's going to be 90 minus 0.62 times your acceleration time, right? This is something that can use to calculate your mean PA pressure, right? So I want you to you don't have to memorize that today. You may not see that on your boards, but I think this is a pretty reasonable equation for you guys to know and use in clinical practice if you're calculating pressures for hemodynamics. All right. What's the mean PA pressure in a patient with a TR peak velocity of 3 meters per second, pulmonary regurgitation and diastolic velocity of 2 meters per second, and right atrial pressure of 10 millimeters of mercury? It's a really, really hard question. So you want to work through it together? So what do they give us? They give us a TR velocity. Okay. So you're okay. So you're talking 4 times 3 squared plus your right atrial pressure equals 46. Good. They give us our PR end diastolic velocity, so we can do that. What's that going to help us get? PADP, right? Good. So 4 times what? 2 squared plus right atrial pressure, right? Which is? Okay, good. So one thing that I'm going to tell you here is that your pulse pressure is your PA systolic pressure minus your PA diastolic pressure, right? That's 20. Okay? So your mean PA pressure, this is something that we didn't talk about yet, okay, can be your PA diastolic pressure plus your pulse pressure divided by 3. Right? That's another way to calculate your mean PA pressure. So here, if we plug our numbers in, we find that 26 right, and that's where we get our number here, right? So I don't want to throw a bunch of calculations at you during the lecture, so we're going to work through some of these questions to figure out those calculations. So far, we figured out our PA systolic pressure, our PA diastolic pressure, our mean PA pressure, right, which we got from a couple different equations, right? We got from this one here, which are PA diastolic pressure plus our pulse pressure divided by 3, right? Or our 90 minus 0.62 times acceleration time. These are things you would just look at the week before your lectures. You always have the ability to calculate these at the bedside. All right, we're going to try to finish up in the next 5 to 10 minutes. And we talked about these already. What is the mean peak systolic pressure of a patient with pulmonary stenosis where the peak TR velocity is 4, peak velocity across the pulmonic valve is 3, and your right atrial pressure is 10?
Okay,
So let's do our PA systolic pressure. What's our PA systolic pressure here? What is it? 4 times 4 squared plus right atrial pressure equals 46. Okay. Is this 46 or 64? 64? 10? Good. We got there, right? Good. All right. Okay, so the gradient between the RV systolic pressure and the PA, right, systolic pressure is the difference between those two pressure gradients, right? Okay, so if we can subtract the gradient across the pulmonic valve, our PA systolic pressure, right, that's going to give us the true velocity in the setting of pulmonary stenosis. Remember, when we talked about 4V squared, right, we canceled out the proximal velocity, right, because the velocity was so low. But if somebody has something like pulmonary stenosis and there's high velocity, we have to think about that as being important in the calculation. So this is kind of an entrance into 2 weeks from now when we're going to talk about hemodynamics, and you're going to be able to understand this fully, okay? But what I wanted to show you was that when you have something like pulmonary stenosis, there's high velocity through that small orifice, and you're trying to calculate your PA systolic pressure from a pressure gradient way proximate to that, you have to account for that pulmonary stenosis velocity in your calculations. So technically, what you would just do is you would use this calculation minus the velocity across your pulmonic valve. So this would be 4v squared too. So 4 times 3 squared plus 10, right, is what? 9 times 4, 36. So your true velocity will be, yeah, 38. 74 minus 36 is 48. It's 38, right?
74 minus 46.
It's 46.
Okay, go. There you go. So basically, all this question is showing us is when we're calculating velocities,
Going to
No, no,
3 squared
4 times
times
3 squared. 9 times 4 is 36 plus.
so it's 46.
46, I'm sorry. So 74 minus 46 is 38, right? Sorry about that, guys. So we'll edit this part out. So basically, the key point that I want you to get to this is when we're calculating gradients, if the proximal velocity is low, then you don't worry about it, right? Like when you're talking about TR jets. But once you add in something like a patent ductus arteriosus or pulmonary stenosis, something like that, then you have to worry about that down gradient when you're calculating, right? So all I want you to know is at the bedside, when you're calculating PA systolic pressures, it has to be in the setting of somebody who doesn't have disease downward from that, like pulmonic stenosis. Okay, that's a really hard question for you guys. And then TAPSE was measured at 6 millimeters in a 47-year-old patient with cardiac amyloid. Which of the following is true? So the lower limit of lower normal limit for preserved right ventricular function is 16. True or false? True. Good. TAPSE represents longitudinal function of the RV. True or false? Good. TAPSE is an accurate assessment of global RV function. Okay. It's longitudinal function. We use it as a surrogate, but it doesn't necessarily always accurately depict that, right? So your answer is going to be A and B. Good. Which of the following is true in this patient with pulmonary regurgitation? RV EDP is normal. Right ventricular stiffness is increased. Systolic reversal of the hepatic veins is present, or tricuspid E to A ratio is 0.6. So this is just to get you through understanding what the slopes of the Doppler signal are. Is this a fast slope or a slow slope? Fast slope, right? It's a very high velocity slope. So what's happening in those two chambers? They're perfect. They're great. They are equilibrating very quickly in those chambers. Instead of something that moves like this, which is more symmetric, right? The chamber backwards in the RV, which is here, this is your RV, must be what? High pressure, right? So which of these makes you think that the person has high pressure in your RV? RV EP is normal? No, right? Good. RV stiffness is increased? Good. So if you see there's this rapid rise here showing you early equilibration in pressures between the two chambers, so you must have a big, thick RV stiffness. Choose the correct conclusion about LV diastolic function in this patient with pulmonary hypertension. So we're taking in a lot to account. So right here we have this is looking at Doppler inflow through the mitral valve, so our diastolic function. And this is looking at our lateral annulus, right, of the mitral valve. So the patient has pulmonary hypertension, right? So what is this? What kind of diastolic pattern is this consistent with? So E to A is what? It's about 1.2, right? Okay. So that's either normal or pseudonormal, right? And then we go to our E prime. Our E prime is 6, which is low, and that's consistent with pseudonormal, right? So this is a pseudonormal pattern in someone with diastolic dysfunction, okay? So what are we trying to figure out? Okay. What would happen if you diarrhea someone with pseudonormal filling pressures? Yeah, so it would go to grade 2 diastolic dysfunction, which looks like this, right? So the answer is B. So this is a patient who has pulmonary hypertension, second to left-sided disease. And that's all this is showing you. So we didn't look at a single thing we talked about today. We looked at left-sided disease process. So it brings the two kind of ideas together. Okay, a 24-year-old man is presenting with shortness of breath. 4-chamber view by transthoracic echo shows distinct abnormality in video 28.2. So what are we seeing here? Good, McConnell sign. Perfect. So what's the answer here? So normal wall motion of the RV apex is seen in akinesia of the basal mid RV wall. Good. Findings are suggestive of acute pulmonary embolism. Check. The pattern can only present in acute pulmonary embolism. No, anything that causes acute pulmonary hypertension can show this. And all of the above, obviously not. E. Perfect. So we're done. So let's review our equations just to kind of get them home, right? So our PA systolic pressure is 4V squared plus our right atrial pressure using our maximum TR velocity jet, okay? Our PA diastolic pressure is equal to 4V squared plus our right atrial pressure using our pulmonary regurgitant jet, right? In this view here at the end phase, right? Our pulmonary acceleration time can help us determine if someone has pulmonary PAT less than 105, right? And for pulmonary embolism, the number that we care about, less than 60, right? That's just to maintain our 60-60 rule. We also know that we can calculate our mean PA pressure using this velocity as well. Can anybody remember that equation? Look at you. I love it. Okay. And those are the main kind of features of what we're looking at here. Okay. Guys have any questions? No? That was a lot, right? And 2 weeks from now, when we're going to hemodynamics, it's a lot. And so try to fully introduce some of the ideas today and use that with the RV. Anybody at home have any questions? Awesome. Thank you, guys.